Welcome. I'm Michelle Cowles, Director of Business Development with Rogers Behavioral Health, and I'm your moderator for today. With me are two experts in the assessment and treatment of depression, Dr. Rachel Leonard, Clinical Director at Rogers Behavioral Health in St. Paul. And she's in our St. Paul location, and Dr. Leonard is the first author of Rogers Clinical Protocols for Depression Recovery. Joining Dr. Leonard is Dr. Adrianne McCullars, the clinical supervisor at Rogers Tampa location. Before we get started, I want to give a quick overview of the format. This webinar is scheduled for 90 minutes. In order to receive CE credits, you must be logged into the webinar for the entire program. We are recording the webinar and will publish it on our website along with the slides for you to rewatch at your convenience. However, please note that CE credits will not be awarded for watching the recording. You must be on the live webinar for its entirety. Drs. Leonard and McCullars will give a 75-minute presentation. Following their presentation, I will facilitate the Q&A session. If you would like to ask our presenters a question during the presentation, please use the Q&A button to send a message. At the bottom of your screen, you simply click on the Q&A button on the Zoom taskbar. I will review the questions submitted, then the presenters will address them during the Q&A portion of the webinar. We do have a large audience today, and we hope to get to every question. If your question is not answered, it will be recorded for later so we can get you an answer at that time. The chat function will not be included on the Q&A, so if it's a question, please make sure it's in the Q&A feature. Now I'll turn it over to our presenters.
Hi everyone, I'm Rachel Leonard. Here we have some disclosures to present to you. Dr. McCullars and I do not have anything specific to disclose. And then here are our learning objectives for today. So our goal is that by the end of the webinar, you'll be able to identify at least 3 activity scheduling examples that are feasible while social distancing. Identify at least 2 strategies for improving group cohesion over telehealth, and then provide at least 2 examples of a values-based behavioral activation assignment that may relate to COVID-19. Here's an overview of what we'll be discussing today. We'll start with an overview of the rationale and theory behind behavioral activation and discuss activity scheduling. For those of you who attended last week, we'll take a little bit of a deeper dive here, and then we will shift to talk through more activity scheduling considerations based on limitations through COVID-19, either via social distancing requirements, stay-at-home orders, or the need for telehealth treatment. So we'll start with some background on behavioral activation. Going through the theoretical rationale and rationale for treatment and discussing activity scheduling. Again, please use the Q&A feature at the bottom and the Zoom taskbar if you do have questions that you would like us to answer later on in the Q&A period. So behavioral activation is a well-established, empirically validated treatment. There have been a number of studies, including several different meta-analyses that have examined BA as it compares to control conditions or other established treatments. And overall, they find that BA performs better than control conditions and either similarly or better than other established treatments. And the one that's been most frequently examined is BA versus cognitive therapy or cognitive behavioral therapy for depression. There have been a number of studies looking at BA for different populations, including more recent research on BA for adolescents. And in 2016, Elizabeth McCulley and her group did publish a manual on BA for adolescents specifically. There's some data that demonstrates that BA might be more cost effective and easier to disseminate than CBT as a treatment for depression. So I think we'll see what you think after today, but BA in itself is a fairly simple treatment to understand, although there are some nuances to implementing it appropriately. But the goal is that through that simplicity, hopefully we can disseminate and get empirically based treatments to more patients in need. The theory that has informed BA actually dates back to the 1970s with two primary researchers who informed this. So on the right, Peter Lewinson and some of his colleagues discussed this idea of response contingent positive reinforcement as relating to depression, such that individuals might be more susceptible to depression if they're experiencing low rates of response contingent positive reinforcement, and that therefore a critical aspect of treatment to improve depressed mood will be to increase their experience of response contingent positive reinforcement. And they described RCPR as a function of three different things. So first, are there opportunities in their environment for potentially reinforcing interactions? Two, are those things happening in a spot in a way that they can access them? And then three, do they have the skill to do that? So if you think of someone who perhaps is going to school and might experience some positive reinforcement and impact from social interactions, are they in school with people that might end up being feasible friends for them? Are those people in the same classes as this patient? And then does this patient have the social skill to navigate that and actually form the friendships that might have that positive impact? On the left is the role of avoidance as identified by Forster back in the early 70s. The idea here is that a critical and key aspect of the continuation and exacerbation of depressed symptoms is avoidance of a variety of different situations and emotions. And this avoidance feels good in the short term. It can feel like a relief that you're not being as vulnerable. And that is negatively reinforcing, which continues that behavior taking place over time. And then the problem is that that can make the problems worse and worsen depressed mood. So based on that, the goals of behavioral activation are to increase positive reinforcement and to decrease the avoidance over time. Interestingly, behavioral activation in some form or another has been around since the 70s. So stemming from this positive reinforcement idea, very early versions of behavioral activation included pleasant event scheduling. So let's identify different things that each individual patient might enjoy and just have them start doing those things. And the research really supported that people did report improvement in mood by increasing engagement in pleasant events. That then got folded into Beck's cognitive therapy along with some activity scheduling aimed at mastery and accomplishment, and is really that first part of cognitive therapy. The goal there is to eventually help lead to cognitive change, which is different from later behavioral activation treatments. This was examined in a really important component analysis in the mid-90s by Neil Jacobson and his group, where they wondered, what is it about cognitive therapy that is most essential? Is it the full package or is it some aspect? So they compared activity scheduling on its own to patients who received activity scheduling and cognitive restructuring for negative automatic thoughts. And then they compared those two groups to a final group that had the full CT package, including work to restructure core maladaptive schemas. And everyone was quite surprised by the outcome, which demonstrated that all three groups performed equivalently and had similar rates of improvement. And this led people to wonder, why would we do a more complicated treatment that might be tougher to teach clinicians and patients than doing this early activity scheduling version that's leading to equivalent outcomes? And that really started more recent, although I guess now it's been almost 20 years, but more of the recent versions of behavioral activation that are out there. There are a number of different manuals and versions of behavioral activation. Christopher Martel and his group published a book in 2001 and a later revision of that that really emphasized the role of avoidance, the need for functional analysis of symptoms. And then Carl Lejeune and his group developed behavioral activation treatment for depression, which really emphasized the role of an activity hierarchy and including values. And then Jonathan Cantor and his colleagues kind of blended those two into a version of stepped BA that incorporates some tools for deciding which aspects of the treatment might be most necessary for specific patients in front of you. The main point for any treatment to be considered behavioral activation is that it includes activity scheduling. That is kind of the core of what behavioral activation is, and that's something that we will be focusing on quite a bit today. This is the rationale for treatment. So the idea is that some patients will have a clearly identified trigger or life event that precipitated their depression. It could be a breakup, problems at work or school, lack of friendship and social relationships. Sometimes it can be a positive event. Some positive event happens, so I get a promotion, I move for that new job. It's a good thing overall, but now I'm away from my family, I'm away from my friends, and then that can lead to some depressed mood. And sometimes there are small changes that accrue over time that aren't necessarily easily identified for patients, and so they can't always put their finger on any specific trigger, and that's actually fine. The key part here is the link between the two boxes at the bottom. So when people are experiencing painful emotions, some of these might be actual symptoms of major depressive disorder. Some of them might not be. Whatever the patient's feeling, this often leads to this very understandable tendency to avoid and withdraw. And that also is very specific to different patients, depending on the person in front of you, their age, a variety of factors. This could be playing video games all day long, which we see a lot in our teens. It could be calling in sick to school or work, sometimes for physical, talking about physical symptoms and needing to miss, avoiding family and friends, just decreased structure and stopping following any sort of specific routine or schedule, and excessive sleep. Sometimes we'll also see substance use here to cope with feelings. So a variety of different behaviors might fall into this box. And that all makes sense. And so the message we want to send to patients is that there's nothing inherently broken or wrong with you, that these are natural responses to these events that have been happening in your life. Unfortunately, though, the more we avoid, the more these avoidance patterns take place, the more problems might pile up. So maybe you have relationship problems that develop, you lose your job, you fail classes at school, you develop substance use problems. So a lot of new triggers might develop over time, which can keep this cycle going and increase depressed mood over time. But the main point to send to patients when presenting this rationale is that your depression makes sense, that this is a somewhat natural pattern, and then to shift to the message of hope. There are things that we can do to help you decrease this cycle over time and to help you feel better. And so here, I know there's kind of a lot going on with this diagram, but basically what we want to do is gradually decrease those different avoidance behaviors, and at the same time, gradually increase engagement in active coping. And that will look also different depending on the patient, but we'll target specific categories of activities. And then over time, we're kind of reversing that cycle and improving mood. The mechanism of action suggested for this treatment is that activation that we're seeing, and there's some support for that. And the goal is for patients to have a number of different types of activities and domains of their life that bring a sense of enjoyment and meaning to their life, to not only help their mood now, but also to help them be less predisposed to depression in the future. When explaining this model, as I said earlier, it is kind of a straightforward idea, but we don't want to make it sound, it's an easy idea to understand, but it's not easy for patients to implement. So we don't want to send this kind of just do it message that, oh, this is super simple, why haven't you been doing it? Or to assume that they haven't been trying some of this already. So it's good to ask for their reactions and see what they have tried over time. It's important to be hopeful and confident that this will work for your patient, and right away to start talking about the fact that we will take a graduated approach. Patients often will hear this and become fairly overwhelmed that we might ask them to completely change their activities overnight, to go back to exactly how things were before they were depressed, expect way too much. So we want to set reasonable expectations so that they don't get overwhelmed or drop out of treatment. So we'll take very small steps. We're going to work together. We'll be getting input from you to guide what we do next. And then we want to get their reactions about the model and talk through any questions they have. In addition to these patterns, which sometimes are called traps and tracks, so trigger response avoidance pattern or trigger response active coping. In addition to those happening on this broad scale to relate to overall experience of depressed mood over time, we can also look at this on a smaller everyday level where there are many different interactions and opportunities for patients to make a choice to either engage in active coping or to avoid. And part of our goal as treatment providers is to kind of train them in that process so that they don't automatically jump to avoidance and can stop themselves and hopefully make a choice that will help them feel better and keep them from avoiding. Here's an example of what kind of one of these everyday interactions might look like. So the avoidance pattern, let's say they fail an exam as a trigger, they feel sad and hopeless, and then they avoid by staying in their room, sleeping, stop studying, they're not engaging with friends online or texting on their phone. And here you'll see that avoidance really is in response to those painful feelings. Does nothing to address the trigger. Instead, active coping or alternate coping might look like getting a tutor, talking to their professor, doing more studying, looking into extra credit, getting a study partner. So really here addressing the trigger itself, despite the painful feelings that are happening. And then hopefully over time that is reinforced. So in this example, perhaps they feel a sense of control and mastery by taking these steps. Hopefully they do better on their next exam, which leads to more positive feelings and then reinforces the use of those coping strategies. So the core intervention then within behavioral activation is to come up with specific activation assignments. And those activation assignments are informed typically by an activity monitoring process to get a better sense for what the patient is doing at baseline when they start treatment and how different activities might impact their mood. The activity scheduling then will follow along 3 different primary categories. One is routine activities, activities of daily living, general hygiene, and consistency within their overall schedule. Another is pleasant or enjoyable activities, making sure that they aren't also avoidance behaviors. And then the last is valued activities. And some versions include an activity hierarchy, some versions don't. I really think that's helpful to lay out the groundwork and have a plan with your patient for exactly how you're going to gradually take these steps over time. And even if you don't have that full, beautiful, complete, perfect hierarchy, we want to get patients started as soon as possible. So getting some initial activity assignments assigned to your patient on day 1 can be really useful. And after that, I will hand things over to Dr. McCullars.
Thank you, Dr. Leonard. Hi, everybody. I am Adrianne McCullars, like was already introduced previously. One thing that I also want to throw in there as a spinoff of the TRAP track that Dr. Leonard was just speaking about, something that we say is you're working with the patient to help them get out of that trap and then back on track. So that's kind of a really helpful slogan, not just for us as the providers to remember, but also to throw out there for the patient. It's catchy, it's fun, and it can help provide that additional layer of motivation, which is sometimes really helpful with some of our depressed patients. So moving forward, what Dr. Leonard was just talking about with the activity scheduling, there are 3 different things to consider when you are doing this with your patients. So first, we're going to talk a little bit about those routine activities that go into that. So routine activities, those are the things that we have to do all the time. We typically don't say, oh my gosh, I just love washing dishes. Like doing laundry is my most favorite thing, but that is what we think of when we think of those routine activities. Regardless of us liking them and not liking them actually, and not wanting to do them, we still have to complete those every day, usually for health or just quality of life, to make our home environment a pleasant place. So some of those examples I already gave, but some other ones are showering daily to make sure that we are staying healthy, brushing teeth regularly, making your bed, things that we might not really consider as a routine activity, but doing things like this can really help somebody feel that mastery of accomplishment throughout their day. So making the bed, doing laundry, eating regularly, 3 meals a day, maybe even some snacks that are built in there as well. Maintaining a regular sleep schedule. Having a very consistent sleep schedule is very important. It can help decrease feelings of depression. Getting somebody back on that schedule with an appropriate bedtime and appropriate wake up time is very important. Helping someone pay their bills. So this is something that oftentimes gets forgotten about. Maybe the person who's been very depressed for a long time hasn't gone to check their mailbox for some time, or when they check the mailbox, they come in and they just put these things down on the side table by the door, and they're really never looked at again because that person's just really not feeling up to it. So that's also an important activity to think about when you're considering some of these routine things. And also the last one as well, checking or going through the mail, which within the mail could be some very important bills that that individual may need to attend to. Okay, next slide. Oh, there it is. Okay. So in trying to assess what are some of the routine activities that may be relevant for your patient that you're working with, you want to ask them a few questions. It's always helpful to figure out where they're at the current point prior to figuring out where they need to get to or what plan you are going to make for them. So you want to ask them based on their average behavior in the recent past. So you don't want to just know what they've been doing right before they entered into treatment. You really want to get a good, well-rounded assessment of their average behaviors from the recent past. So you want to ask questions like, what is your typical sleep-wake cycle as is? What is it like during the weekdays? What does that look like on the weekends? Are they drastically different? That's something that you definitely want to take into account because their weekend planning may inherently look a little bit different than the week plan that you might have through the Monday through Friday. And then also, what time are you going to sleep? What is their bedtime? Are they staying up very late and then waking up very late? Are they staying up late and having to still wake up very early? And that's not really helpful for them. What are they doing that's keeping them up that late? Things like that. A lot of different Q&A that you can ask them to really figure out what is going on. So you have a really good understanding of what their routine is thus far and how you can help them and work with them to improve that, to hopefully help, decrease their symptoms and then improve their level of activation. Also, you want to ask questions. How many times are you showering? Are you showering once a week right now? A couple times a week? Are you only showering when you leave the house for errands or doctor's appointments? That's also very important for you to know. How many times a week are you brushing your teeth? Same thing. Is that once a day? Is it less than that? Is it only before you might see someone or before you go out to the store or to an appointment? And then how many times a week do you do laundry? Is that happening at all? Is there a large amount of clothes that is just sitting in the bedroom that's appearing very daunting and it's not getting done? Definitely not on a regular basis throughout the week. And then if they're not doing that laundry, is there somebody in the home that has been maybe accommodating them or assisting them with these tasks? So that way they do still get done, but that person's still not actively taking that responsibility to do that laundry task or any other task in the home that might be. So that last question actually can give you a little bit more information on what the level, is there any involvement of someone else in the home that you also may need to take into consideration when building their activity scheduling. Next slide. So the next piece, aside from routine activities, you also have enjoyable activities to consider. So enjoyable activities, when someone is depressed, as you can imagine, those typically tend to decrease in how frequent that person ends up doing them. And they also, even if they are doing it, even at a less frequent rate, they may report just less enjoyment in that activity as compared to previously. And one of the most important things to do is help to increase these in order to help decrease their symptoms of depression. So they may report that, oh, they might still do X activity maybe once every couple weeks, but when they do it, they don't feel good. They don't like it anymore. It's not fun anymore. So that might be something that you hear. So things within the enjoyable activities category. So it could be those activities that you used to enjoy. So whether you're doing them or not doing them still, things that you used to do and get great enjoyment out of those. Activities that you currently enjoy. So there might be some things that you are still doing and you enjoy them just a little bit and you still feel depressed, but you still get a little bit of enjoyment out of those activities. And so another way to say this is, what are those activities that make you feel slightly less bad? So what are those activities that make you feel slightly less bad is another way to phrase that for your patients. And then also there might be some activities that maybe they had on their list of things that they wanted to do, or maybe they wanted to try prior to feeling as depressed, but maybe they haven't done that yet. So those are things to consider for that enjoyable activity list as well. So after those enjoyable activities, next slide, we have one more category. But first, before I talk about that, I'm going to talk about the enjoyable activities list. So the important thing with these enjoyable activities is, yes, you need to work with your patient to figure out what are things they did before, what are things they are still doing, and then what are some things they wanted to do but haven't yet. But you're not alone in trying to figure this out. Sometimes patients, it's hard for them to come up with these things because they're just not able to get outside of their own worldview and think of different ideas or even things from the past. It's just really hard for them to think about things like that, but you're not alone. There are different enjoyable activities lists that you can give the patient, and y'all can work together to see if any of those on that list were some of those activities for the past, are some of the activities currently, or things from the future that the patient had maybe thought about but really hadn't engaged in yet. So they can fill out this list and you can work on it together to develop those things as well. Next slide. So one thing to consider when you're discussing enjoyable activities, some of those enjoyable activities may have also started functioning as an avoidance pattern. So within that TRAP track, these may be some things that would be considered within that box of that avoidance pattern. So some common examples: video games, watching TV, talking on the phone, surfing the internet, things like that. Some of these activities could not be a good idea to recommend to that person to do because they may already be doing them as a way to cope with those unhelpful emotions or those painful emotions. But there are some others that maybe you can incorporate as long as you have reasonable amounts and reasonable limitations that are surrounding those, and maybe pairing them with something else. Next slide. So for those activities that may somehow serve as an avoidance function, here are some different things to consider. So you may want to set a time limit for that activity. So maybe that person was playing video games for an hour or 2 hours. Maybe now you set a limit where it's 30 minutes because it is an activity that they do enjoy. But when they go over that 30-minute period, we know that it turns into an avoidance pattern at that point. And then the next piece to consider, wait to do that activity until they have met their specific goals for the day. So maybe they also need to shower or brush their teeth or do other ADLs that are important. Maybe even they need to focus on a few minutes of schoolwork and maybe calling their mom or calling a friend. So once they do those things, they then can play video games without that time limit because they've also accomplished a lot of other things on their list. And then you can do a combination of those two. Just like from what I said before, you can still set the time limit for those, but still make it contingent upon other things that still need to get done off of that list with ADLs or other activities that are routine or pleasurable. And then sometimes you may also need to consider just taking the activity out altogether. Is that activity something that that person really, really values? Or is that something that the person is just doing just to help them avoid those painful feelings or any other activities that may be going on? Maybe they're playing the video games for 2 hours to avoid having to do some of the household chores or to avoid having to engage with family or friends. Those are things that you might consider cutting, maybe even at first, just to help the person build a better foundation and then maybe reintegrating them later, but that would be on an as discussed basis. Next slide, please. So the last thing to consider when you are trying to develop an activity scheduling routine for the patient is the values component. So values have been adapted from the ACT by Hayes, and you want the individual, the activity scheduling to include meaningful and important activities. So those value-based activities, not just pleasurable ones and not just routine ones. You also want a lot of those activities to be directly in line with that person's values, because we know when an individual is engaging in activities that are directly in line with their values, they do start to feel better. They don't feel so incongruent. So that is definitely something to put when you are discussing things with your patient. And these activities are related to the values that that patient really finds personally meaningful and also possibly reinforcing. Next slide, please. So one of the ways to figure out what are those valued activities is by using a values assessment form. So on that form, you will have the different values components, so family, friends, academics, things like that. You will have the person rank those. Obviously, the lower ranking ones like 1, 2, 3, those are going to be the values that the person holds closest to them or values the most. And then you have them discuss what type of person would you like to be in this area. So what would you like this to look like? In an ideal world, what would this look like for you? And then you have them respond based on how they think they've been doing in that area in the past month. And they can say things, not good. I really haven't been doing what the type of person I want to be in that area. You can talk through those things with the patient. And then the next thing to discuss, setting those immediate concrete goals. Well, how can we get you to that place where you would like to be in that area? And let's do that by setting some very specific and measurable goals to get you there slowly over time. So that at the bottom of this slide, there's other categories to consider, and there's different values assessment forms, but these are the other ones to consider: education, security, safety, things like that, that you really want to know, are those important to your patient? And then you'll more than likely have them pick the top 3 values that they rank, and go from there. You don't want to be too overwhelming. You really want the top values that they find meaningful, and then you want to go from there. Next slide. So here's some example of some values-based BA assignments. So this person obviously put family and or friends at the top of their values assessment. So calling their mom 3 times a week and talking for 20 minutes about topics that are not related to their symptoms, not related about treatment. Just how is the day going? What's happening today? Not focused on symptoms and treatment. That's a very important piece. Practicing the piano 30 minutes each day. Working on college essays for 20 minutes a day, 3 days during the week. Volunteering at a food pantry once a month. Playing with their younger sister if family was very important and they felt like maybe they've been isolating from their younger sister more than they would want to. So playing with the sister for about 30 minutes twice per week. Looking for jobs online, 30 minutes a day. Small, manageable things that they can do over the course of time to then help them get back to where they would like to be with regards to that value. So now I'm going to turn it over back to Dr. Leonard to continue discussing.
Thank you. So based on those 3 different categories, as well as any information you learned from your patient when discussing the rationale for treatment and that TRAP-TRACK model, we want to start putting together specific items for that activity hierarchy. And so here are different questions to ask to help you build a very comprehensive and specific hierarchy that's applicable to the patient in front of you. So what things are they avoiding? What did their life look like before they became depressed? Sometimes too, we'll build in kind of a magic wand question here. So if you had a magic wand and could feel completely non-depressed and content, what would your life look like? What are the things you'd want to be doing then? What does their routine and general schedule look like? You can use that routine assessment that Dr. McCullars went over a little bit earlier. What did they previously enjoy? What are their values? And sometimes this can take a little longer to identify with some patients. Typically the routine and even enjoyable activities can be fairly easy for patients to identify and report to you, but sometimes they really don't know what they value, or they've been living their life based on what parents value or what they think their friends value. And so this can require a little bit more time and conversation to help them identify that piece of the hierarchy. We also want to know how different activities impact their mood. And that activity monitoring can be really helpful here to identify maybe things that they wouldn't have otherwise reported, but that show a shift, a positive shift in mood over time. And then if they did have any specific triggers that they need to problem solve or work on, we can fold that in as well. So if they lost their job and an important piece for them is to find a new job, we can build in steps related to that into their BA hierarchy as well. And of course, we will talk with our patient, ask them lots of questions to get the answers to these things and identify specific activity assignments to give to them. And we can make use of different treatment forms and assignments to inform that as well. For those of you who are familiar with ACT, we will fold in some of the values assessments and tools, metaphors to help people identify their values for this purpose. I think, one of my pet peeves is that a lot of people will say to me, I'm already doing BA. I'm having every patient take a walk. I'm having every patient do some arts and crafts, and they're all engaging in schoolwork. Done. So that, I think there's, some usefulness potentially in some of those activities, but we need to make sure that anything we're assigning is specific to that patient. So we don't want to have a list of kind of go-to BAs that every single patient gets, because that's not necessarily going to be effective, and some patients might hate some of those activities. So we really want to make sure that they're specific, they're appropriate for that patient, and that they are laid out in a groundwork where we know exactly what's expected. And so here, the SMART goal framework can be really helpful. Exactly what is the activity, what do they need to accomplish it, how long are they expected to do the activity, and how frequently are we going to have them do that. And one of the ways to kind of build in that graduation within the hierarchy and break things down into manageable steps is to alter the duration and the frequency so that over time we're expecting them to engage in some of these activities more often and for longer durations. And that's the important piece with being graduated. We want to increase that difficulty over time. And so we will have patients rate on a scale exactly how difficult or overwhelming they think each activity would be, and then use that to build the hierarchy. And of course, as Dr. McCullars reviewed earlier, we want to make sure we're not assigning anything on the hierarchy that is avoidance. So in the example she gave of somebody playing video games for too long, even if we're saying, okay, we'll allow you to play 30 minutes per day after you've completed all of your treatment assignments and schoolwork, I'm not going to put that on the hierarchy if that's something they've been doing for 3 hours per day previously. It's more of an activity that they'll be maybe permitted to do if they can do all of the other things that are actually more challenging and not avoidance behaviors for that person. Here's a very little example of what a hierarchy might look like. We'll frequently end up with hierarchies that have 50 to 100 items, but this snapshot is really meant to demonstrate a few things. One is that you want to have buildup of specific types of activities within the hierarchy. So here you'll see maybe they start by getting out of bed at 9:30, they build up to 8:30. So we're making that more challenging over time. You'll also see that there's all three different activity categories represented here. So there are some of those routine activities, they're showering, they're getting up at a specific time in the morning. There's enjoyable activities represented. So maybe they really enjoyed yoga in the past. So we have that here. We have watching a football game with friends. And then we've got some valued activities. Maybe they wanted to work on being a better friend to their best friend. So we're going to fold in some phone calls to that person. Maybe they have a value of education and they want to get into college. And so working on some of those college applications could be a really challenging but important valued activity for them. So that's kind of an overview of behavioral activation and focus on activity scheduling kind of more generally. And now we wanted to shift and talk through more of these considerations that relate to our current situation with the COVID-19 pandemic. We've heard from a lot of different providers that they're really struggling. A lot of their go-to activities might be really challenging right now. So how do we work on that when there's all of these different limitations that might make traditional behavioral activation assignments more challenging? So first we'll start with activity scheduling. And here, there's a number of challenges specifically that relate to social distancing and stay-at-home orders. I know each state seems to call it something slightly different, but we don't have as many opportunities for reinforcement in the environment. So thinking back to that early theory and the concern over deficits in response contingent positive reinforcement, we're creating a situation where there might be many fewer opportunities for reinforcement in their environment, decreased access to that, and at times some of those skills barriers as well. So some of these challenges include that we can't assign for patients to do a lot of public activities right now that we might have previously assigned for them to do. They most likely aren't able to interact with a lot of other people in their lives, in person at least, aside from those individuals that they might live with. And there are challenges to exercise and movement. So things they might have been doing to be healthy, to improve mood with exercise might be a lot more challenging under the current circumstances. And then overall, there are also these additional concerns with structure and consistency. So even those of us who might not be struggling with depression, I know a number of people are changing their sleep schedule because they're at home all of the time, or they might be struggling to put on normal clothes and wearing lounge pants every day, maybe showering less. So for someone with depression, that might be even further exacerbated and become more problematic over time. And so going back to that enjoyable activities list, a lot of things might have been feasible in the past, but might have required going to a gym, interacting with other people, going out in public. So how do we do some of these things while social distancing? And I'm going to turn that over back to Dr. McCullars.
Thank you. So like Dr. Leonard just said, how do we do these things now that this has created a large, seemingly barrier for a lot of the treatments we were doing prior to COVID? So here are some ideas. Obviously, we've had to rely pretty heavily on the use of technology in order to interact with other people. So one thing that has been a helpful activity for some, teaching family members how to get on the internet, how to use the video chat, how to use different software so we can communicate with each other. So it's not only a learning opportunity for one, but it's a teaching opportunity for somebody else. And also can be a pleasant activity for that person to be engaging in, because not only are they connecting with somebody, but they're showing them how to do something and just getting that sense of mastery doing that as well. And we all know that sometimes teaching someone to use these devices can be challenging. So to get it done, that is the ultimate best feeling. So that's something that with the use of technology has been very helpful also. Video chats, people chatting with each other via video, via Zoom, people are using Teams. They've also now have these virtual book clubs where you go to a specific link, you read the book that is there, and then you have like a virtual chat with those people to keep people connected. Because before, people who do book clubs, I know a lot of people that do regular style book clubs, those were not allowed anymore. So now everything became virtual to help with those activities, to still achieve some points of connection with others while social distancing. Virtual game nights are also something that has come up. People are playing very large games with each other on Zoom. It doesn't matter. Monopoly I've seen played. A lot of different card games I've also seen played. And that just creates a really fun environment for everybody to still connect virtually during the social distancing time. Movie nights with other people, also something that I've seen happening and can be really helpful. You're with the person, you're watching the movie, you're able to communicate and chat back and forth while the movie's happening, just like you might in a movie theater, but it's just a little bit different because you're not in person with them. Cooking with a friend, like while you're on video chat. So I've seen a lot of people have the same recipe. And so they, either FaceTime or Zoom that person, and then they work on cooking that recipe together, which is fun. Each person can compare like how theirs came out. Like, oh, what does yours look like? What does yours look like? Oh, I must have done something wrong. So it's just a fun way to still stay connected with people. Next slide. Also, there are some additional things to be considered for those who might not have people as those points of connection to chat with or to call over video. So these more solitary activity assignments. So on YouTube and just on the internet in general, there are so many different videos to find where you can learn a new craft, like crocheting, knitting, learning how to paint, things like that, that you can watch someone do and really learn that new craft on your own. The next thing is there are some free like university classes that people can enroll in to do a course during this time of social distancing, which helps them learn about a different topic that maybe they were interested in and hadn't thought of doing it before, but now is a really good time to do that. Learning to practice a musical instrument. Again, plenty of videos on the internet for how to do that. And then a lot of people do have these instruments. I have a personal example of this. My husband actually has a bongo drum, or whatever kind of drum it is, as well as a trumpet. He has decided that now is a good time to begin practicing the trumpet. This is an enjoyable activity for him, not so much for me, but he's gotten quite good because there's a lot of these videos that he's able to do and listen to in some of this downtime that he might not have had time for before, or really might not even have thought about until now. Again, working from home, both of us there, it can be difficult when he practices the trumpet with me present, but again, that's something pleasurable for him that he has found to do during this time of social distancing. Also exploring different museums, zoos, or cities. There are so many links now to do these, they call them virtual field trips for zoos, museums, going through certain cities. So even if you're in a different city other than your own, even if you're in your own city, you can explore a city that's not yours, something that you might have wanted to travel to or just wanted to learn more about. They've created all of these wonderful links for that, for people not only just to do who might not have someone else to communicate with, but also just in general. It's a very fun thing to do. And then redecorating is another thing. So redoing the furniture or, moving things around, changing up the vibe of the home environment is also something that can be done during this time of social distancing. Next slide. Also, if there are family or roommates that are at home, so obviously this is on a case-by-case basis because not everybody is going to have family or roommates in their home. But if you do, potentially working on a new home improvement project, gardening or doing something in the kitchen that maybe needs to be fixed, general redesign or redecorating together, maybe painting a new room in the home or giving it an accent wall, things like that. Learning a new hobby together, doing a game night or a puzzle night. I know a bunch of people have really gotten into the puzzles and putting them together, doing these very large puzzles, and each night taking so much time to put in some of the pieces, which elongates the activity, but it's also a nice activity to do together during maybe that 20 or 30 minutes of puzzle time. playing sports in the yard, putting together a scavenger hunt for maybe the kids or other people in the home, together learning a new recipe that you can, do together as a family. Maybe each person can take a role in the recipe, chopping or cooking or whatever it might be. So everybody is able to stay involved. You can learn a new dance together. You can also make a TikTok. That is definitely a new thing that has happened. TikTok videos are very, very popular right now. A lot of people are doing them with their family. A lot of people are actually doing them by themselves. And then just taking time to learn more about each other. So asking different table topic questions or conversation starters with each other, just to learn a little bit more about the people that you might live with, but maybe there's more to get to know during this time. And then making plans for the future. So talking about, maybe next year, what trip might the family go on? Or what might we be doing then? Just to help make plans for that time. So that way we're still enlisting some of that hopefulness. Next slide, please. There we go. So there are also some alternative solutions for activity scheduling when it comes to values as well. So how can they find meaning in their current experience? How can they maybe help to contribute to those others who may be really struggling? So some examples of things that can be helpful to meet this category: writing letters to the elderly, writing letters to healthcare workers, doing chalk on the walk. I know now when I take my dog on a walk, there's all these really, really cool motivational quotes, cool designs, like cool drawings that are on pretty much everybody's little driveway or the sidewalk right there, or even into the street if it's a nice new paved road. So I know that when I walk, it's very nice to see those things. So that's something to think about doing. Decorating windows and doors. I know there's a few subdivisions around the area that I'm in. The children of the neighborhood have all drawn these rainbows, and they've posted these rainbows on their windows. And so a fun activity for families, they walk around the neighborhood and the kids find the rainbows and they count how many rainbows there are that day. And that's just like not only a fun-filled family activity, but it also addresses that valued piece as well. Other people have learned how to sew masks or make masks and donated them or provided them to people who were in need. Creating care packages is another one for those that they love and maybe they can't see, or for healthcare workers in need who may be constantly at these medical facilities taking care of those who are sick. Next slide. So some alternative solutions to exercise. So a lot of people have had to, a lot of the gyms are closed. A lot of the fitness facilities are not open right now. So what can we do to still incorporate this component into people's routines and people's schedules? There are, again, a lot of YouTube videos, yoga, different cardio videos that are out there, strength and body weight videos. I know some facilities are even putting out their own videos for their members to utilize during this time, which is very helpful. There's different online exercise routines, so things that you can go through. They give you a very structured setup. You go through the different activities for every day of the week. Also, there are some specific fitness apps that have free trials where they have specific types of workouts, specific things that you can do on that app during the free trial. Also, going outside, if you're at a place where you can walk or even hike, go biking, things like that, that might not be your typical exercise routine, but are things that you can incorporate to get yourself out of the house and still facilitate a little bit of that cardio activity that you might be used to. Dancing with their children or family members or even their roommates. Again, a lot of TikToks, a lot of videos have been put out there of people getting together and dancing and doing fun things like that. Learning new dances has been a big one. And learning a new dance, I mean, I know Zumba, and Zumba can be pretty difficult, and that's dancing. So this is also a nice addition to an exercise routine when we're talking about different options. Next slide. So these are some different creative ideas. This Olympic swimmer, I don't even know how that's happening, to be quite honest. It must be some serious core strength. I don't even know. But the next one on the right, there was a video on Facebook of this gentleman who is shown putting soap on the floor, puts a few dashes of water down, and he starts walking as though he's on a treadmill. I have personal experience with this one because I saw it and I was like, that's hilarious. I'm going to try it. So I did. I made a specific TikTok video out of it, but let me just tell you in general about this experience because it's pretty funny. The guy on the video makes it look really easy. And I don't know what kind of soap he used, but I used Dawn because that's what I had in the kitchen. Squirted the Dawn on the ground on my tile floor and then put a few drops of water on it. It was very slippery. It was almost so slippery that I couldn't even stand up. It was almost like I was a newborn baby deer or something. And I nearly collapsed onto the ground and I had to basically be lifted off of the spot because I couldn't get out of it. It was pretty bad. But once I was able to wipe up some of the water and the soap, it was actually very much like a treadmill. I did get a little nice workout in. But I will also tell you this, Dawn on a tile floor, even after being wiped up, seemed to be like Pledge on a wood floor. So just keep that in mind if you try this one, because my tile floors are still pretty slippery, even with socks on. So that's just a side. But anyways, that's my story about the treadmill in the kitchen. If you try it, just beware with the soap water ratio. Next slide. So a lot of people, have said, oh, it's very difficult to do some of these things via telehealth. And that is definitely true. It is very difficult. And it is also very different than what we are used to. But what we've also found is that there are some really, really good benefits to this as well. And I don't want those to go unnoticed. The biggest benefit is that we now have access to the patient's home environment. We can see what they see. We can see their living space. We can see them when they're doing these ADLs. We can watch them brush their teeth. We can encourage them to go do it and then come back to the screen and let's talk about how difficult that was for you and what that was like. We now can prompt and help people in real time do a lot of these tasks that are very, very difficult for them. Doing laundry, having the patient bring that laundry basket over to the screen and just fold some clothes for maybe a couple minutes, helping them to get some of these tasks done in a very slow, manageable way that then they start to develop that mastery. And also another thing that's been really helpful with the telehealth environment, it has reduced pretty much all barriers to treatment, and it has really increased attendance overall. Patients are no longer having to drive here, traffic is not an issue, different barriers in the morning really aren't happening because all they have to do is get up and maybe go to their dining table or go to their desk to start the treatment day. So it has really resulted in a higher attendance for treatment overall. And for some people, starting treatment over video or, via this computer base has been a much easier place to start for them. It feels a little bit safer. They just don't feel as vulnerable and it's easier for them to open up and get started with treatment. And it also helps reduce a lot of avoidance as well, helping them make that first step. So despite all of the challenges that have come about as a result of having to switch to telehealth and still apply these modalities there have also been a lot of positives that have come out of it that we really didn't have access to before this, and that have really, in my opinion, elevated the treatment platform. And with that, I'm going to turn it back over to Dr. Leonard.
Thank you. So next we wanted to shift gears a little bit and talk about building rapport and group cohesion when using telehealth. This is another challenge that we have been facing as we've moved to a lot of telehealth treatment. And how do we address that, and how much of a problem is this actually when using telehealth? So I did look into some of the research related to this. There's some evidence actually that rapport and the therapeutic alliance over telehealth might not be that much negatively impacted by the telehealth format. So it might be pretty close to the therapeutic alliance you can develop with in-person treatment. There was a study very recently by Lopez and colleagues that found that group treatment, I think this was a DBT intervention, delivered over telehealth did result in some decreased group cohesion when compared to that same group treatment offered on an in-person basis. So they found that the telehealth group felt less connected to their peers and did report lower group cohesion, although, as Dr. McCullars mentioned, they actually did have better attendance. And somewhat surprisingly, they did report similar levels of patient satisfaction And I think, something that we need to consider is that right now, it's not a perfect world where we have many options. And so it's not as though we're often comparing telehealth to in-person treatment, although some of that might change depending on the state where you're located. But certainly there's reason to believe that this is better than nothing and can still lead to significant improvements in symptoms. Another recent study, this one wasn't specific to telehealth, but I thought was still somewhat relevant. They found that therapeutic alliance, but not group cohesion or therapist competence, predicted reductions in distress following a group-based, mindfulness-based cognitive therapy intervention with cancer patients. And so perhaps the group cohesion isn't as essential as that therapeutic alliance is for those outcomes. And we do have some reason to believe that that alliance can still be strong when using telehealth. So here are some recommendations to assist with building rapport and engagement over a telehealth format. First, it's important to make sure that you are centered in the camera and that you're close enough for patients to read your facial expressions. There may be some need to somewhat exaggerate your expressions to make sure that they're evident to patients participating in telehealth. And it's also important that there's a high-speed connection so that that feedback is done on a real-time basis. If the patient's disclosing something vulnerable and challenging for them, there's nothing worse than having a significant lag before you can respond and they can see that empathy and response from the clinician. It's also important to look into the camera rather than where you see the patient on the screen. I know this is something that I struggle with and can be challenging to remember. So I've got Sophie the giraffe there. So all of you parents are likely very familiar with Sophie as I am. I had a colleague who had the great idea of putting Sophie on her laptop, like right behind the camera, as a reminder to look in the camera. So you could use a toy, you could use stickers or stars or whatever you need to do to remember to periodically at least look in that camera and try to connect with the patient. For the initial meeting, there were some creative ideas that I found in the literature for younger children. They are at home, so they could get up and get their favorite toy and share that with you and talk about it to build rapport. They can draw a picture and then hold it up to the camera. You can share the screen to show them how things work and maybe decrease some of their anxiety about using the computer. I saw one example where they gave kids a keyboard that wasn't connected so they could feel like they were typing just like the adults. So there's a lot of creative things you can do. With adolescents and adults, it's especially important to talk through confidentiality concerns, especially as that relates to disclosure and rapport building. So making sure, especially if you're working from home during this time, that they know that there aren't any other people in the house who can hear the session, who might interrupt the session, who could see the video, so that they feel comfortable disclosing. And then at the beginning, it's important to ask directly about their opinion of telehealth and any questions or concerns that they might have over the telehealth format so that you can work through those together. For group participation, it's also important to set up some ground rules. So I know there are some funny videos about Zoom meetings and virtual calls. But one thing that is a constant struggle is this feeling that you're talking over one another and then multiple people are speaking, you can't hear anyone, gets kind of muted out. And that can also increase anxiety over speaking out of a fear that you're going to offend someone or don't know when to talk. So for group, it can be really helpful to set up some ground rules for how people will know when they can speak or how they can indicate that they'd like to say something. Sometimes using the chat feature can be helpful for that. Even hand signals to the camera can be useful, but having that system up front can be very helpful. It's also important at the beginning to talk through the need to mute the microphone when not speaking and to minimize distractions. So not just being on mute, but making sure that the background is clear of other people, of other distractions, that they're not typing and engaging in other work on their computer during group. They don't have family members or roommates coming in and talking to them while they're on mute and the whole group is watching this. So making sure they're aware of all of those confidentiality and other rules to make the group run smoothly. And again, having that confidential private space So there's been a lot of concerns. We've got a lot of patients who are engaging in telehealth from home where their whole family is working at home, homeschooling, and maybe they're in a shared space. They're in a living room or something. That doesn't work well for group, especially if other people are in that area. So if a parent, if a sibling is in the background, then of course that makes it tougher for any other group members to want to disclose, and there are confidentiality concerns. So we are requiring up front and talking very explicitly about the rules that they're in a confidential private space, that they won't be interrupted. They can put a sign on their door. They can let people know that they're in the middle of something and nobody else should be entering that space. And then for groups in particular, when doing telehealth treatment, it's incredibly important to try to make it more engaging. So building in some visual aids and props can be very helpful for this purpose. So we found that PowerPoints to display key messages for a group, especially if there are pictures or diagrams or things that might be more challenging to convey otherwise, can be very helpful. Even just sharing a screen and pulling up a Word document where, as group members provide ideas or answers to questions, you can type in what they're saying and really make it specific to that group. Showing videos that are relevant to different treatment topics and then having conversation around that. Of course, these are things we might want to do at times in person, but become even more important when engaging in telehealth treatment. Zoom and a lot of different telehealth platforms do have whiteboard features that can be incredibly helpful. Sometimes there are limitations to the ability to use those. So here in the picture, you can see someone's just using an in-person small whiteboard that they have to write some notes and then showing that to the camera. So getting creative in how you can still provide some of those visual aids and notes for your patients to see during groups. And then I will pass it back to Dr. McCullars.
Thank you. One thing I do also want to say about the visual aids, an additional thing to use aside from a whiteboard that I recently thought of, those large Post-it note things that are sticky. You can put it on the wall behind you and kind of use that almost like a backdrop or almost like a large whiteboard. It's not, you can't erase from it, but it's also something to think about having as a resource. So how can we help build cohesion within groups via telehealth? It can be kind of difficult when you're trying to initiate a group discussion via the telehealth platform. And it can also be difficult to have the patients feel connected with one another, feel connected with you as a therapist. Different things like that have been tricky to really get going on the front end as compared to in-person treatment. So some things to think about in order to help build that cohesion. Icebreakers are really helpful here. Having people go around and introduce themselves, saying a fun fact, or saying something, XYZ about themselves. 2 truths and a lie is something that's pretty fun too. And then everybody gets to kind of participate in that. You can also allow a little bit of unstructured time for the group members just to engage in a little small talk. Obviously, you'd be there to monitor that to make sure everything remained appropriate, but it's a really good thing to potentially consider using as a reward. If you do X activities throughout the treatment day, then we're going to set this up for 15 minutes to give patients like a break, but it's like a virtual break where they can kind of also socialize or chat with one another or just share some appropriate small talk. Next slide. So again, you can have like a list of questions and then have the participants read 1 or 2 to really help provoke some thoughtful conversations, getting to know one another. There's a specific website here in helping facilitate those different questions and divvying them out among members as well. So a lot of different options that are available, even like topic cards, if you have some of those, just to facilitate specific group discussions on stuff that might be a little bit more lighthearted than maybe the topic is going to be, but it just helps facilitate that group dynamic and then that group cohesion, allowing the participants to also engage in the materials, maybe reading from specific materials, taking turns, things like that. Next slide. Also, games have been really helpful. So we've definitely utilized games and different activities. We typically incorporate these on Fridays, you know, as part of a group, as just a way to kind of be fun and lighthearted and allow the patients to interact with one another. But categories, Jeopardy, apples to apples. I know one thing that we have started to incorporate is patients doing just like a mini talent show. So maybe they are displaying a specific BA activity that they've recently gotten really good at. If it's something they've started to practice again and really do in the clinic, they do a little bit of a talent show that is monitored by the therapist, but it gives them a point of connection. It allows them to show different things that they've been working on, and they found it to be very helpful. So that's also something to think about and consider if you have a large enough group to be able to do that. So I think now I'm going to turn it back over to Dr. Leonard so we can talk a little bit about a sample case.
Thank you. Yes, so we wanted to try to kind of tie this together for all of you with an example. So I will present the case, and then Dr. McCullars will talk through some example activity assignments that might be a good fit for this patient. So Maria is a 20-year-old who identifies as heterosexual and female. She is on leave of absence from college due to her symptoms of depression, and she's had difficulty making it to classes and completing her coursework in the past. She's living at home with her mother and her 15-year-old brother. She's showering about twice a week and struggles to keep her room tidy or help her mom around the house. She is avoiding interacting with her mom and her brother, and she's also been avoiding interactions with her friends, although she does value these relationships and feels guilty that she's not engaging more often. She sleeps 10 or more hours per day and is spending significant amounts of time scrolling the internet and social media on her phone. She has stopped exercising and engaging in other hobbies, which previously included reading fiction novels, singing, writing poetry, and drawing. She also used to spend significant amounts of time with her friends at their apartments, going out to eat and doing group exercise classes with them. The stay-at-home order has Maria feeling more hopeless and motivated.
And Rachel, if you'll just stay on that summary slide just for a second.
Mm-hmm.
So after Dr. Leonard has read that, you can kind of see the different areas in which Maria is struggling, or maybe there has been a change from before. So specifically within the routine category, you can probably see showering, cleaning, doing chores, and even schoolwork is suffering here. Within that enjoyable category, you can see that exercise is something that she used to do but really hasn't been doing as of late. And then from the valued category, you can see relationships, specifically friends, mom, and also brother, is something that as a clinician should be running around in your head when you're thinking about potentially developing that activity scheduling. Next slide. So when we're talking specifically about the activities for Maria, starting with those routine activities, incorporating some more showering, helping make the bed multiple times per week, showering again. So you'll see that there's a gradual increase in these activities in which she's struggling. You will also see that some of these things, even though they're starting at the less difficulty, they're going up in difficulty level. So you really want that, like Dr. Leonard already said before, you know, these slides are meant to show a couple of different things, not only the specific activities, but showing how we increase the difficulty over time. But these are the specific routine activities for Maria that you might want to consider if you were working with her and developing this. Next slide. So looking at the enjoyable activities, so exercise was definitely one of them, reading, drawing, things like that, that would want to be incorporated with her on this list. Again, you will see that things are increasing in difficulty, and there's a bunch of different options on here, from reading, drawing, assisting someone cooking dinner, texting someone to help reintegrate with her friends, video chatting, doing an online yoga class, so reintegrating her back into that exercise environment that she really liked to do before but has since stopped. And then next slide. And then when thinking about the valued activities for Maria, these are some things that you would also like to consider. So incorporating mom into these activities, because she did mention that that is something that she really values, mom, brother, and friends. So taking a walk with mom. School is something that she values and has really been avoiding that. So doing some of those steps to get back into college. What does it take? Let's look that up for 10 minutes twice a week. Incorporating mom and brother with dinner, gardening with parents, parents, video chatting her extended relatives, such as her grandparents, completing specific applications. So all of these would go into that valued category for Maria, and is something to be discussed and added to that activity hierarchy. And again, you'll notice that they're very gradated, and they increase in difficulty slowly. So she's able to work up to those more difficult items.
All right, and with that, we will take some time for the questions and answers that you have submitted. And remember, if you have any questions that you haven't yet submitted, you can use that Q&A button at the bottom.
Thank you very much. We'll now go through the questions. We have several to get through. The first one is, how do you move forward with activity scheduling during the pandemic and outside of the pandemic for patients who are in a that'll never work headspace?
I can start, and then if you have more to add, please do, Dr. McCullars. I think that's a challenge we see frequently. You should expect that patients are not going to be motivated to do this treatment, and that they might be somewhat pessimistic. So I think that going through the model can be helpful in building hope, but then also going back to that patient's experience. So have there been any times when they didn't feel motivated, but they did something and it went well for them? Have they noticed even small shifts in mood with specific types of activities? If a little bit of willingness to do some of that activity monitoring can sometimes help them see, oh wow, you know, my mood does change even just a little bit as I'm doing some of these different activities, to get that hope and kind of build up from there once they're perhaps a little bit more willing to try.
Thank you. The next question is it safe to do BA via telehealth with patients who are at high risk for suicide?
That's something we've really struggled with. I think it depends on a number of factors. Certainly, even now there are still inpatient hospitals that have beds available, and so a careful suicide risk assessment should always be done at admission, and a higher level should be considered if needed to keep someone safe. If they're not admittable to an inpatient facility, we are faced with some challenges because there might not be as many options for in-person treatment. So we might consider, hey, this is somebody who should engage in telehealth, but coming into our clinic and we're monitoring them while they're engaging in telehealth because we have a few staff on site. If that's not an option, is any engagement in treatment better than nothing? But then can we continue to monitor and ask about safety every time? So we absolutely would still do BA with patients with safety concerns, and we would fold in more suicide risk assessment, safety planning, means restriction, possibly at distress tolerance skills on an as needed basis as well.
Thank you. The next question is, do you find, whoops, I'm sorry, the screen flipped. We got a bunch of questions at once and our screen flipped up. I work with teens and I am finding that they are having the hardest time with maintaining a regular sleep schedule. What would be the best way to help with that?
I think part of it is figuring out like what the struggle is. And so doing more of an assessment of what's getting in the way. So are they just sleeping excessively because they aren't getting up in the morning? And we have a number of different strategies to work on that people really dislike, like having parents come in and open up the shades and the covers, or having alarms across the room and different strategies like that. If it's more on the front end where they're struggling to fall asleep, we look at sleep hygiene and how can we challenge them to make some changes in their sleep hygiene to make their bed more conducive to sleep, for example, or if they're getting stuck ruminating before bed, help them disengage from rumination and engage in some mindfulness or some relaxation exercises to enhance sleep. So So it really depends on what seems to be getting in the way, and then finding a targeted intervention for that.
And one thing I'll add to that too is really discussing what does their day look like? Like, is it scheduled? Is it not scheduled? That could also influence the sleep patterns as well, whether it's waking up too late or too early or going to bed too late. So you want to know what's going on in their day-to-day as well.
Thank you. The next question is, do you also use BA to treat bipolar depression?
We will use BA to treat the depressed phase of bipolar disorder, often in conjunction with medication strategies and other strategies that might target bipolar disorder more broadly, but certainly for the depressed phase, we will use BA.
Thank you. When to recommend medication if patient is not responding to BA?
I think that's a challenging question, especially for me as a psychologist. You know, we see a lot of patients who are more severe or who've had depression for a number of years. We often are treating patients at a, partial hospitalization level of care. So certainly if it's at that point, there's often a combination of behavioral activation with medication. If a patient hasn't had depression for too long, if their symptoms aren't quite as severe, if they're a little bit naive to empirically based treatments, it might be worth trying BA on its own and seeing if they can benefit from that. But when it becomes more severe, sometimes we're able to use the medication to improve engagement in behavioral activation and energy levels, for example. So when treatment isn't progressing well, that's when we would really think about that combination.
Thank you. The next question is, do you address the client's self-talk, especially negative, during BA activities?
That's a great question. I can take this one if you want, and then if you want to add to it, Dr. McCullars. So we do, but we do that in a very different way from what a lot of clinicians are used to who have been more familiar with cognitive therapy or CBT. So often that negative talk gets in the way and can really reduce any sort of other potential positive impact of an activity. So they might be taking a walk on a beautiful day, and if they're beating themselves up mentally, or if they're ruminating, they're not going to get the same benefit as if they're taking that walk and really appreciating the birds chirping and the sun shining on them and all of the things. So we encourage people to notice when that's happening and then really shift their attention away from that process and engage in mindfulness of their current experience and especially of valued activities that they're doing. So more of a contextual shift and a shift in attention than really engaging further with the content of those thoughts.
Thank you. The next question is, do you have suggestions for BA activities for couples?
Do you want to take that one?
Sure. That's a really good question. I think all three of the categories can apply to couples as well. Working together they can work together to do household chores. They can work together to do enjoyable activities, also valued activities, creating a list of things that they're able to do together. So I think the same principles can be applied. It's just the nature of the activities may look a little bit differently, and it's definitely going to require a conversation between the couple in figuring out, are there some activities that they used to do, maybe they'd stopped, or maybe they would like to do, but they haven't done yet. So incorporating those, and then also making sure to include those routine as well as the valued activities too. So I don't have any specific suggestions, but those exact same principles could very much apply. Dr. Leonard, I don't know if you have any additional specific examples for that, but that would be
great.
Just the same.
Mm-hmm. I think some of the deep questions or those conversation starters be not as appropriate for patients and might be more couple specific. So you can find different lists that can really help build intimacy between relationship partners and kind of vulnerable disclosure. And so those can be really useful as well.
Thank you. The next question is, any tips for helping caregivers motivate the client to reduce avoidance? I work with children and I have a difficult time getting the caregivers who are also low functioning with a lot of depression themselves to motivate and help the child.
Yeah, that's really challenging. We would, of course, if the caregiver is depressed, encourage them to get their own treatment. In addition to that, especially with kids, but honestly with adults too, we do use a lot of reward systems to encourage engagement because these things are really challenging for patients to do. And kids especially might not be as motivated. They might not see why some of these things are problematic. Like, oh, I'm not going to school anymore. That's great. Why does that matter? So trying to help build in rewards where if they engage in X, Y, and Z treatment assignments, or they just participate in treatment, they show up, then they can earn points towards a toy that they want, or they could earn cell phone time or video game time or something that they are motivated to do. Now the challenge sometimes becomes getting parents or caregivers to be on board with withholding those things when the rewards aren't earned. And so a lot of parent education and support can be needed. Sometimes having family sessions where these things are explicitly discussed to get the child to kind of see the reason for it and somewhat agree will help the parents get more on board. But of course, kids aren't always super excited about that, but trying to get creative in how we can build that motivation and have those rewards in place over time can be helpful.
Thank you. I think that we have time for one more question. The next one is, do you find that with screening of clients' hygiene prior to admission could prevent them from entering a program?
That's not something that we've been into too much. I think certainly if there are really significant problems, such as like incontinence or something like that, that would need to be addressed for them to be able to engage with peers and certainly could have social consequences as well. But generally, we anticipate that there are challenges with hygiene, and we will work with people from wherever they start treatment. We do have to have some conversations that some of our clinicians might not feel as comfortable having until they get used to it, about body odor in really non-judgmental ways, with a lot of normalization of how depression can impact behavior and kind of working up from there, and really getting a detailed picture of exactly what they're doing and not doing as it relates to hygiene, so we can very kind of gradually step things up. Now, sometimes if there are significant deficits, we might move more aggressively up the hierarchy than we would otherwise if we feel like it's a health issue, for example, and then we'll have to build in more support and reward around that.
Yeah, that's what I was going to say. Unless there's a significant health issue that is stemmed out of the lack of self-care over a period of time, that would require a different route, possibly.
Okay, thank you. And thank you again, Drs. Leonard and McCullars, for taking time away from your clinical practice, as well as sharing these valuable insights with us. I'd also like to let you know that Rogers is here for those who are struggling with mental health or addiction, now potentially more than ever. We are continuing to accept patients in both inpatient and residential settings in Wisconsin. And we're also very proud to now be offering Rogers Connect Care, our virtual option for those needing intensive outpatient levels of care. Drs. Leonard and McCullars, before we conclude, please share your recommendations on additional resources for our participants.
All right. So here are just a few resources either related to the current pandemic and information that's evolving there. NIH also has some specific information related to coronavirus, the APA, and then I also quite like the Anxiety and Depression Association of America website. They have a lot of different anxiety resources as it relates to coronavirus and other strategies that are specific to the current pandemic.
Thank you. That about wraps it up, everyone. I just want to remind our participants that those of you who met the required time commitment will be eligible for CE credits. You will receive an email with a link to the mandatory evaluation form. Once you complete it, you may download your CE certificate for the event. We will have a recording of today's webinar and the slides available on our website, rogersbh.org. If you were unable to join the first webinar series, Treating Depression with COVID-19, please visit our resources section of our website, rogersbh.org, to watch it at your convenience. However, please note that CE credits will not be awarded. Next week, on Thursday, May 14th, we will offer the first of a two-part webinar series on treating trauma. Keep an eye out in your inbox for details. On behalf of everyone at Rogers, we look forward to partnering with you to help you support your patients. Thank you.